So let's begin. Hi and a very good evening. I would like to welcome all the participants tonight, quorum and non-quorum members. And it is my pleasure to introduce our guest speaker tonight, the founder and the president of quorum himself, Dato Dr. Mehesh, to share some insights about colostomy. Why is it needed, the procedures of opening and closing it, and as well as other related issues. But I think before we start, we should take a moment to get to know our speaker. So please allow me to read about Dato Mehesh for a while. Dr. Mehesh is a specialist in general surgery with a subspecialty in colorectal surgery. He is currently serving at Pantai Hospital Kuala Lumpur. He received a Bachelor of Medicine and Surgery in 1993. He then continued his studies at the Royal College of Surgeons of Edinburgh, Royal College of Physicians and Surgeons in Ireland, as well as a degree in surgery at the National University of Singapore. Dato Mehesh served as a specialist at Kuala Lumpur Hospital and Seremban Hospital for 3 years, starting 1998, after which he pursued training in colorectal surgery in 2001 at the Academy Surgical Unit, Nottingham, and the University of Hull, United Kingdom. He successfully obtained a fellowship in colon and rectal surgery there. He started serving as a general and colorectal surgeon at Pantai Hospital, Kuala Lumpur in 2004. With almost 30 years of experience, Dato Mehesh is a past president of the Malaysian Society of Colorectal Surgeons, MSCRS, a council member of the Asian Pacific Federation of Coloproctology, APFCP, and a regional vice president of International Society of University Colon and Rectal Surgeons, ISUCRS. I think it's worth mentioning that he can speak English, Malay, Punjabi, Hindi, and Cantonese. And I think we should also take this opportunity to congratulate Dato for receiving the Noma and Gil Award just recently, which recognizes his contribution to educating healthcare professionals, patients, and caregivers about colorectal cancer. Now, without further ado, let's welcome Dato Mehesh.
Okay, thank you, Sarah, for the very kind introduction, and a very good evening to everyone. And first and foremost, I think I need to congratulate the people who have this, events or this shows, this talks, webinars ongoing. A big thanks to Sarah. This is the very first time I'm, meeting up with yourself, but I heard so much about you, and I think I really need to congratulate you for doing a wonderful job. And of course, with the other council members, Inche Hamid, Ms. Wong, Dr. Nadia, and everyone else, who had relentlessly, make this, event, a huge success. So, I've been asked to speak on stomas. I just had tweaked the subject matter a little bit. I'm just going to share my slides. Sorry. Yeah. So I just tweaked my presentation a little bit. Instead of just highlighting on colostomies. Colostomies, as we know, is basically involving just a large bowel. I thought probably quite a fair number of patients of ours are also in ileostomy. So in the general context, I just thought of making a heading speaking in regards to different types of ostomies related to both the GI as well as very briefly on urostomies. I'll touch on that later on as well. So again, very simple. If there are any questions you have, if you want to interrupt me along the way, you can do so, or you can save the Q&As towards the end of the presentation. Yeah, we'll make this very informal kind of a session. So I'll talk a little bit about, what the indications are, how we create the stomas. I've got a short video presentation on how I create an ileostomy, to share with you all. And we'll touch very briefly on some simple complication and things like that. Yeah. So first and foremost, to understand the terminologies, the word ostomy, basically, it arises from a Greek word meaning a mouth or an opening, right? And so when you talk about ostomies in the surgical practice, it's any procedure where we exteriorize a hollow viscera, meaning to say any situation where we are bringing out the hollow viscera to the exterior, right? It can even be in the GI-based situation, for example, something called a tracheostomy, where a trachea, is exteriorized. Not exteriorized, where there's a tube is put in the trachea. It's called a tracheostomy, where there's an opening made in the stomach to feed patients. For example, a tube is placed in the stomach. Sometimes we have those situations in people who are bedbound, stroke patients. They can't feed orally, so we create something called a gastrostomy. All right. So again, ostomy just is simple word which implies any situation or condition where a hollow viscera is being exteriorized. Okay. Obviously, in our context, in today's presentation, we'll be focusing predominantly on the bowel-related ostomies, which is the two common ones are the ileostomy and the colostomy. All right. So, and of course, the other thing is the ileocondy or the urostomy. So one of the intestinal stomas, generally they are unfortunate, but sometimes necessary outcome of intestinal surgery. Nobody likes to have a stoma, but in some circumstances, we have to create a stoma for certain situations, right? Some are unavoidable, whereas others are formed after some kind of consideration of risks or benefits a stoma may provide. And in some circumstances, the stoma are life-saving in nature. In certain emergency situations where, we just have to go in and out through a stoma, and that can be life-saving in nature. So the GI ostomies are created in a variety of medical conditions. I think the thing that hits our minds most often will be cancer. Obviously, yeah, cancer is probably the highest need for stomas in our context. In some countries, for example, where there's a very high incidence of inflammatory bowel disease, the incidence of stomas for IBD conditions may be high. Fortunately, we don't see that very many in our context. We see a lot more cancer patients here. So cancer is probably the number one condition wherein we would subject patients to an ostomy. All right. So colitis can be in a form of IBD, inflammatory bowel disease, can be ischemic, infective in nature. There's another condition called diverticulitis. Some of you all may be familiar with this, where the diverticulums are little pouches in the colon, and sometimes when the pouch gets inflamed, they can rupture, they can result in sepsis. So in some circumstances, patient requires an emergency surgery for diverticulitis, and they may also end up with a stoma, a temporary stoma. And of course, trauma, any accidents where there's anal sphincter damage, very bad damage to the anal sphincters, impalement injuries, and so on. Sometimes we have very bad motor vehicle accidents where there's what we call an open book fracture, where the pelvis is laid open and so on. So we have no choice. We have to create a stoma to divert the patient's feces. Congenital anomalies, in some circumstances, unfortunately, sometimes some babies are born with congenital anomalies, and amongst which one of those are something called an imperforate anus, where the baby is born without an anus. So in those circumstances, of course, the baby cannot poo, so we give them a stoma bag, and then as an interval procedure, they're subjected to various operations in order to create an anal canal, an opening at the back passage. Right? So sometimes ostomies are also necessary in newborn children as well. And rarely, sometimes in very severe anorectal sepsis. Very rarely do we create this. I've had encountered a patient, very elderly person with very bad perineal sepsis because an abscess and venous gangrene at the bottom, so with the feces passing through the back passage, the wound will never going to heal. So those circumstances, we divert the feces, so that it can pay more focused attention on the sepsis. So even anorectal sepsis is among the conditions that sometimes the stoma is necessary. But again, top on the list, again, just to reinforce, is cancers, right? Now, before we start talking about ostomies, I thought probably just give a brief outlay about the common oral colorectal procedures that we may encounter, right? You may have heard of some of these terminologies, some of these conditions you may have been subjected yourself also, right? So if you look at this, I'm not sure you can see the cursor here, but you see all these are numberings on the colon, and these basically just signify the incidence of cancers in different parts of the colorectum. Now, if you look at it, the cancers of colorectum are mostly prevalent on the left-hand side, predominantly the rectum and the portion called the sigmoid colon. Almost 2/3 of cancers we see is located in this area, and then the incidence depletes as we go proximally, and then incidence becomes high again on the right side of the colon, right? So this basically, so the most often surgeries that you may have heard about is, if, for example, tumor sitting on the right side, we will subject a procedure called the right hemicolectomy. A tumor sitting in the upper part of the right side is an extended right hemicolectomy. I'll explain to all that in a short while what I mean by all these terminologies. Left side, left hemicolectomy, Hartmann's procedures where we resect the colon, segment of the bowel, and we close off the distal end, and the proximal portion is brought out as a stoma. And the more common operations for cancers, as we know, would be anterior resection, a low anterior resection, and ultra low anterior resection. These are tumors situated in this area, in the rectum or the sigmoid colon. So, okay, so these are terminologies that you may have heard more commonly. Some of you all may even have encountered these procedures. Abdominal pulmonary resection is a situation where the tumor is sitting very low down in the anal rectum, and we can't preserve the sphincters, and we have to resect the entire sigmoidal rectum, and the patient ends up with a permanent stoma. So when you see an APR, it just means to say that they have to have a permanent bag in the end. Restorative proctoclectomy was the entire colon rectum is removed. In some rare circumstances, patients with genetic cancers, for instance, we have to do that. We take out the entire colon or rectum and then restore the continuity to the anal canal by creating what's called a pouch using the small bowel. I'll speak about that in a short while as well. So again, this is another simplified diagram of the entire colon or rectum. Now, this branches that you see, they signify the blood vessels. Okay, this is very important for us as surgeons. Whenever we do surgery, we have to identify and know where these blood vessels are. Because when you talk about surgical resection, it's not just removing a segment of colon, we have to know which vessels to ligate. Because cancers, they will spread along your lymphatics, and lymphatic channels run along your blood vessels, right? I know there's a few technicalities here for you, but I thought probably I'm trying to make it as simple, so at least you understand when we talk about surgery, what do we necessarily mean to do? So, for example, if tumor sitting here in the right side colon, we can't just go in and resect this and say we've done the job. We have to ligate the vessels supplying here, the right colic, the ileal colic, and middle colic here, right branch and middle colic. And when we do that, the blood supply here gets the entire part of colon gets devascularized. So we end up resecting this part of the colon, the right side of the colon. All right. An extended right hemi, we tie up the middle colic vessel here as well. And so there's more extended resection. And the left side, for example, rectum and sigmoid, we end up tying off the inferior mesenteric branch here. So that vessels, so ligate these vessels, so we have a proper oncological clearance when we do a resection. When you talk about cancer surgery, we always have to talk about the margins of resection. So it's not just a tumor situated in one area, the margins are very crucial. Yeah, and all the lymph nodes draining that area, that has to be resected as well. Now, very briefly, the three simplified way of describing the purposes for creating a stoma, functional reasons being for as a covering stoma, diverting or venting. Now, what does this mean? A covering stoma just means to say where we resect the part of the colon rectum and then we anastomose the remaining part of the bowel, but in order to rest the anastomosis, we bring out a temporary diversion bag, and that's called a covering stoma. So usually, very classically, it is following a low anterior section, right? Whereas again, in this diagram here, the blue-gray color is basically a segment it's removed, and then we bring out the other portion of colon rectum down, and we anastomosis here. So whenever there's a low anastomosis, low rectal anastomosis, it's always preferable to rest that anastomosis by giving out a temporary covering ileostomy or a stoma. All right. So this is one of the commonest indications for a stoma as of today, right? A low anterior resection as a covering stoma. A diverting stoma is where, as the name suggests, we're just diverting the fecal material through a bag. Whenever the segment of bowel is devascularized, the segment of bowel is not very healthy. So simple solution is just to divert that segment of bowel by bringing out a stoma. Venting just refers just to air the segment of bowel is entirely dilated, distended. Like, for example, this segment of bowel is totally distended, secondary obstruction, bringing out a stoma as a venting stoma. Now, a few preoperative pointers to highlight before we create a stoma. Number one is basically have providing proper counseling to patients. I think this is very relevant primarily to the nursing staff or the enterostomal therapist. And whenever someone's subject to stoma, it's obviously for them to accept, understand with the function, the need of stoma, we need to counsel them beforehand. Now, this is not always possible in all circumstances. Sometimes, in some circumstances, where surgery needs to be done as an emergency, there may not be much time for counseling and so on. But as far as you can, whenever in elective cases and so on, it's always good to prepare the patient, to at least the expectations can be met to some extent. Yeah. So it's always good to counsel patients. So it helps them to expedite and ease the post-op recovery and meeting of the expectations thereafter. It's also important, if we can, and again, for the benefit of intrastomal therapists and nurses, to know the time, the diagnosis as much as we can. What is the type of surgery the surgeon is planning to do, the surgical incision that is about to make, and the type of stoma that is going to create, right? And of course, then the other important thing is the patient factors. So when a pre-op counseling is done, the enterostomal therapist, they will come and ask patients a lot of questions. For example, what their work has, their clothing style, the belt line, the religious beliefs, and so on. Do they have physical impairment? So all these things are necessary for us to prep and sometimes even to like preoperatively mark where the site of the stoma is going to be created. So pre-op counseling, again, it may not be feasible in all circumstances, but as much as we can, it's always good to get a patient, to at least the expectations can be met. They can understand what's the need for a stoma and what exactly it entails, and how to look after the back afterwards. So again, now to classify the different stomas again. We just mentioned the difference between a colostomy and ileostomy. Ileostomy just means to bring out a segment of the terminal ileum. A colostomy is a segment of the colon, right? Now, the other way of looking at it, is it going to be a loop stoma or is it an and stoma? These are important relevant factors as well. Now, as a general rule, but it's not exactly cast in stone all the time, but most of the time, a loop stomas are created with the intention of a reversal. So they are temporary in nature. Most anstomas are usually permanent in nature. All right, I'll explain and tell you why is that so. And when I draw, there's some diagrams I'll run through in a short while. So loop stomas, majority of those are temporary in nature, whereas anstomas, majority are permanent in nature. Okay, so the other way to look at it is temporary, permanent, and whether they are being created as elective as an emergency, or what's the purpose of stoma as a covering or a diverting stoma. So these are different ways of division, the different types of stomas. Okay, now this diagram just to imply where stomas generally situated or sited. A desirable stoma location where this ileostomy or urostomy is usually on the right side of the abdomen, at just below the belly button, and more importantly, within the rectus muscle. All right. Now these, if you can look at my cursor, now these muscles are ribbon-like muscles which strap all the way from the xiphisternum all the way right down to the pubis. So now these muscles, they're very strong muscles, and they're a pair, one on each side. So the stomas are generally fashioned through the muscles, and the reason for that is because the muscles do provide a little bit of support to the stoma, and the risks of complications like a retraction and herniation will be much lesser if they are created within this muscle straps, right? So an ileostomy usually is created on the right side and in the lower part where number one is, it's labeled as number one, whereas a colostomy, most of the time, which is a sigmoid colostomy, is here in number two, right? On the left side and below the belly button, and obviously above the pubic crest and pubic ASIS. Transverse colostomies, they are, I'm not a big fan of creating transverse colostomies because they generally are more bulky in nature, and they are usually situated in the upper part of the abdomen, just below the rib cage, right? So again, but the key rule, like I mentioned, is they are situated within the rectus muscles. So what are the crucial sites I need to avoid? Basically, bony prominences. The stoma should be away from bony prominences. They should be away as much as possible. The skin fold and creases, the belt line and the waistline, the incision lines. they are away from the belly button, umbilicus. If there are any associated hernias, they should be away from them. And some people, you've got large pendulous breast, for instance, obviously stay away from them. And of course, some patients who have been subjected to radiation, for instance, radiation sites are to be avoided because skin is already basically irradiated in that circumstance. Which these are rare circumstances, but sometimes you do encounter situations like this. So again, the main things again are to avoid bony prominences, the skin fall or creases. And so even like that's the reason why even like intrastomal therapists, when they see the patient, they have all the liberty to evaluate the patient in a sitting position, in a standing position, understanding where the belt line is. So all these factors are very important and relevant so they can mark out the site where the stoma can be created. Some other important pointers, like I think I just mentioned this, dynamic assessment by nurses in all positions, observe any scars, creases, bony prominences. And I think it's also important, the patient should also agree to where the siting is. And it's also important for them to, if the patient would like to request for themselves that like they would like to have a site of the stoma situated in a certain position, I think it's only important that we address and explain to them that it will not be very feasible or functional in that particular site and why so, right? So it's always important to explain to patients why do we need to do so. And like I just mentioned, it must be through the rectus to provide additional support. And once they agree, look out for a flat surface and mark at the center point. So this is how the nursing staff are usually, advised to and to mark out stoma sites and preoperatively. Now, what are the indications? We'll start with annihilostomy again. I know there's some of these medical terminologies, but like I just mentioned a while ago, the commonest indication for a loop stoma is a temporary stoma to cover following a low anterior resection. Low rectal cancer, a patient is subjected to this operation called a low anterior resection, which I just mentioned a while ago. So when you do a low anterior, we give those patients a temporary loop covering annihilostomy. And these stomas usually are kept for a period of about 4 to 6 weeks, and following which they are subjected to a little study called the gastrographic enema, just to evaluate the anastomosis, where the surgery has been done. So once we get a green light, the anastomosis is looking good, there's no leak, there's no stricture whatsoever, the ileostomy can be closed. So again, this is probably the commonest indication for a stoma today, right? So they can also be done to protect an ileoanal pouch following a restorative proctocolectomy. Not a very common operation, but sometimes you do that, protect an anastomosis and IBD and so on. An angiostoma, like I said, most circumstances, these are permanent in nature. They can be falling, again, proctocolectomy is a situation where we excise them, remove the entire rectum and colon in FAP, for instance, and then these patients may end up with a permanent or an ileostomy. So again, just explain the commonest indication for a ileostomy. I think if you ever have to remember one situation where ileostomy is created, just remember this procedure, a low anterior resection, where tumor or rectum is removed and part of the sigmoid colon is removed as well. And then the remaining proximal part of the bowel is brought down and anastomosed to the lower part of the rectum. And in order to rest this anastomosis, we bring out a temporary loop ileostomy. So this is just to, I know it's a complex slide, but to show what a proctocolectomy is, basically in some circumstances where the entire, what's in red here is the entire disease rectum, maybe in severe colitis, for instance, or more commonly because of conditions like what's called an FAP, which is genetic disorder when patients are at risk of developing cancer. Young people, even their teens may develop cancer. So we remove the entire colon and rectum early in the early childhood, early teens itself, and then we bring out a pouch or small bowel and join it up to the lower part of the anal canal. And when you do this procedure, we bring out the temporary loop ileostomy just to rest the anastomosis. Again, this is an example of a situation where the entire colon and rectum has been removed. And if you look closely, this patient has got a multiple small little tiny polyps, if you look at them very closely. So this condition called FAP is a genetic disorder where classically they describe it as a carpet of polyps. So the entire colon is just studded with polyps all over. And patients with FAP, usually they can't escape cancer. So the important treatment is to remove the colon rectum prophylactically. So before they develop cancer. So sometimes they're done in the late teens or even early 20s. We have to consider doing this procedure. Right, just some simple graphic images to explain what a loop stoma is. Basically, as the name suggests, it just means bringing out a loop of bowel outwards, exteriorizing outside, making a nick on one end, and which is usually close to the distal segment, and then everting it backwards. And if you look closely, the proximal end, that means the upper end, which is the functional end of the stoma, usually has a little spout. Spout means it's projecting upwards, whereas the distal end is usually flush to the skin. Why is this important? Because we know the contents of the ileostomy, they're quite irritant in nature, and sometimes when they come in contact with the skin around your stomal area, peristomal skin, it can really irritate and cause some damage to the skin, and which is quite a common problem, which is encountered predominantly by the enterostomal therapists and nurses. So peristomal excoriation and problems are quite common. And in order to minimize that problem, usually a creation of a stoma with a good spout will help to minimize those problems. Again, a simplified way of describing, where loop is brought up and then the spout is created at the upper end. There's an example of an ileostomy. Again, it's also known as the Brooke ileostomy, but described by a prominent surgeon called Brooke, James Brooke. And again, bringing out the stoma and everting it backwards, and creating a spout. So like this is quite a nice spout. It's projecting outwards. And so it's always easier to manage this kind of stomas. So again, I think I just mentioned this earlier, stomas, whether it's ileostomy or sigmoid colostomy, they're generally permanent in nature, right? So now the preference between different types of stomas within loop ileostomy or loop transverse colostomy, natural fact, there isn't a general consensus which works better, but majority of patients we know would have a loop ileostomy because it's always easier to create a loop with a lesser infection rates, and it's always easier to close a loop ileostomy as compared to a transverse. And transverse colostomies, some would prefer doing that, but they are more bulky kind of a stomas, and the incidence of prolapse usually much higher in a colostomy as compared to an ileostomy. The only downside of an ileostomy is basically because the contents are more proximal in nature and is all small bowel contents, so the effluent that drains out usually is more pasty or liquid in nature. And it's also imperative that these patients are advised to make sure that they hydrate themselves well, maintain their fluids and electrolytes. Otherwise, they can be subjected to, episodes of dehydration or even sometimes renal impairment. Just to share a little study again, there isn't a strong evidence to show, but there's always a preference towards a loop ileostomy compared to a transverse colostomy. Now, speaking of colostomies, I think, again, very briefly, I'm going to touch just two of these indications. The one I just mentioned earlier was an abdominoperennial resection, where we can't preserve the sphincters because the patient's got a cancer sitting very low down the anal rectum, and we have no choice but to resect the entire colon rectum, close the anal canal, and give patient an stoma. So that's a permanent stoma, right? And another condition which sometimes may have been encountered in certain emergency situations is something called a Hartmann's procedure. I'll show a diagram in a short bit where even a colostomy is done, but these are amenable to a subsequent reversal thereafter. So again, APR, abdominoperennial resection, is where you got tumor sitting right down in the anal canal. And so there is no space, for us to make an anastomosis, and we can't preserve the sphincters. So we have, so these are patients, unfortunate patients, who have to be subjected to an abdominoperennial resection. So resect this part of the colon rectum with the lymphatic drainage and so on, and bring this portion out as a colostomy and then stoma, right? Now, but fortunately, and APR indications are very much lesser now as compared to a couple of decades ago, because there's so many techniques now wherein we can subject a person to a low anterior resection or ultra low anterior resection with just a temporary divergent stoma. So previously, those days, even a tumor was sitting about 5 cms from the anal verge, used to be subjected to abdominal parallel resection. But now we can go down even as much as low as possible, 2 or 3 centimeters, and giving even a 1.5 centimeter margin below to do an ultra low anterior or even a transanal joint anastomosis below. And this is just to minimize the need for a permanent stoma. So sphincter saving procedures nowadays are more prevalent as compared to decades ago. So, but in some rare circumstances, we don't have a choice, and abdominal parallel resection or APR is inevitable. Yeah. So Hartmann's, again, a situation sometime in person comes in an emergency, or there's a perforation or a perforated diverticular disease where a segment of colon is removed, and this portion of colon is brought out. So the disease segment in the sigmoid here is removed, and the descending colon is brought out as a stoma, and the rectal stump is kept in place. It's closed up, it's sutured here or stapled across and kept in place. So this basically, there's still and a way of anastomosing in time to come. But a Hartmann's reversal, it's quite a tedious of a task, because going down, look at them, many of these patients, when they are subjected to initial surgery, they are subjected to some form of sepsis and so on. So having them to go through another major operation sometimes will be an issue. So a lot of these people who are elderly people, multiple comorbid problems, they may not have a reversal. They might just live on with a permanent stoma thereafter. But Hartmann's procedure generally, it can be reversed, unlike an abdominoperennial resection or APR that I spoke about earlier. So stoma reversal process, the high rates of complications for Hartmann's reversal. So a lot of people, they do not undergo reversal, and they live through the physical and psychological morbidity of a stoma. Now, a refined stoma basically is just making where, in some circumstances, we create a stoma through just under local anesthesia. Some people are not fit for a major surgery, for instance. They're not fit for general anesthesia, where a stoma is inevitable, where just a circular disc is made on the skin to deliver a segment of bowel, and then bring out a loop of bowel upwards, and then creating an ostomy. Now, I'm just going to share a little video clip of a patient who had a low anterior section for a low rectal cancer. We've already done the initial surgery, and there's plasters are where the ports were inserted. There's a small wound here, basically for the liver of the specimen, and I brought out the stoma at the end of the operation just to cover the anastomosis. Right. So it's a very short clip, which I'll just run through. Just hang on, just a minute. Micro 3 already done. Is this method? Micro 3. So this is passing what's called the cerebromuscular sutures, right? This is the distal loop, where we're just securing it to the skin. So this part of the loop is the one that's created and made flush to the skin. So this is a non-functional end of the loop. Yeah? So this is how a spout is basically created, right? So we pass two bites. One is basically at the point where the opening is made, and then about 3 or 4 centimeters more proximal to that. We pass another in the sutures in the seromuscular layer, and then to the skin. And I'll show you how I do the eversion. So just starting a couple of sutures at angles and 3 different stitches on each side. I know this is a bit technical, but I just thought probably since I think Sarah did mention if I'd show a video, either the closure or opening of the stoma. I can't remember which one, but I thought, okay, I'll just share this one with you. So at least you'll understand how stoma is created, right? I know it's not a very um, nice video to watch if you just had your dinner. Uh, so okay, so that's how I do a spout creation, right? So I just insert, pass through, just keep the band tension, and then pass a little back off underneath, and then just do create a spout to begin with around. So these stitches that we utilize are vital sutures, polyglycolic acid, and they are generally absorbable stitches which need not be removed. Okay, right, I think okay, I think it's the tail end of the clip. Okay, let's move on then. Now in this time and age, of course, in the era of minimal invasive surgeries, you may have heard a lot of something which we do occasionally just to deep dive with the fecal material prior to subjecting patients to neoadjuvant therapy. So in this circumstance, we don't make any cuts and all that. They're just 2 or 3 holes which are created, and one usually near the belly buttons where the camera is inserted, another 1, 2 holes, and then we bring out the loop of bowel, and a stoma is created thereafter. Now, very briefly, I'm just going to mention 1 or 2 words on urostomy or ileal conduit. Sometimes the urologist, they will call us in to help them. And sometimes we need to do this, not just for bladder cleanses or very advanced pelvic tumors, where we have to do something called a pelvic exentration. Pelvic exentration is a situation where we take out all the structures in the pelvis, the bladder, the rectum, in women, the uterus and the vagina, everything all comes off because a very advanced tumor filling the entire pelvis. And the patients may end up with 2 stoma bags. One is the colon, the colostomy, and one being the ileal conduit, where the urine diversion is done as well. So urostomy is basically a situation where, the bladder is removed, and the ureters, which drain from the kidneys, a segment of small bowel is utilized, and the ureters are implanted to the segment of small bowel, and which is brought out as a stomal bag. Now, this is just example of a patient who had advanced prostatic cancer, very rare kind of sarcoma of the prostate, which is a rare kind of tumor where the entire bladder, uterus, and rectum, everything's removed. And they got like this being the urostomy, where the urine's draining out, and this is a colostomy with a colon for the fecal material. So it's very unfortunate for the patient to have 2 bags, leave alone one. One is already quite, troublesome in some people, but in rare circumstances, when the exentration is necessary, which again can be life-saving in some patients. And they may have to live with dual stomal bags. Now, I think I'll skip this part of okay, maybe I'll just run through it very quick. So ERAS is basically a simple surgical terminologies for patients, for, what we do in post-op care for patients in an immediate post-op period. Now from this current time and age, we have gone are the days where patients, they stay in the hospital for, 2 or 3 weeks after surgery. We usually get patients up and about and mobile within just a couple of days, within a day or 2 after surgery itself. So ERAS, that's what ERAS approach implies, where, early removal of all the structures, all the tubes and so on, to get patients up and about. What I tend to do is when patients have had surgery and a stoma is created, I think the first appliance usually applied by the surgeon and on the operating table itself. It's very important to ensure that, the first bags they apply are transparent in nature, because for the initial few days, it's always important to visualize the stoma and to look at the color of the stoma. And sometimes the stoma, if there's impediment in blood supply, the stoma can become very dusky and ischemic in nature. So if you have a very opaque bag, you can't see it. So transparent bag, very important to visualize the stoma, and that's very important daily practice. And also look at the effluent. What's the color of the fluid that's draining out? Is it blood stained, or is it, bile? Is it bilious, or is it fecal material? So all these are important things that we need to address or look into after surgery. So regular inspection on daily basis is important. It's always important to encourage the patient to take interest in stoma. In children, even as children or elderly people, sometimes they may have some caretakers, so we can get them in the picture and so on. And so at discharge, usually the intrastomal therapies will give a list of various kind of requirements, the bags and so on. So I think essentially when it comes to ostomy creation, it's always a combination of a good teamwork. So it's not just the surgeon alone. There are a lot of people, the intrastomal therapists, they play a very important role as well. Yeah, but this is in reality, however, we know for a fact, I think the intrastomal therapy nurses will encounter this. Almost half of ostomies usually may result in some degree of problems. And many of these, the common problems are usually related to the skin-related issues or periostomal excoriation or some sort, or some degree of pouching difficulties. And usually these are most crucial within the initial period of creation of stoma. But thereafter, when patient becomes, they understand the techniques of how to manage this problem, they become more mature into handling them themselves. So the initial period post-operatively is not uncommon for patients, to have to encounter problems of stoma. And most problems usually are due to poorly constructed or sited ostomies. And when this happens, it results into all forms of increase in healthcare costs as well, medical care costs. resources are increased, and so a lot of logistical issues come into the picture when patients are encounter difficult stoma. So very briefly, now just to imply what are the complications. I'm not going to go very much into the complications. I think there's going to be an entire different foray or chapter to talk about, but I'm just to highlight very simple um, categorization of different problems that some people may encounter when they have their stoma created. The most common problems are peristomal related, and this implies things like because of the contents and the effluent of the bowel contents coming in contact with the skin, resulting in irritation. And sometimes they can have problems because of the wafer, the bag itself, or the application of the stoma bag, which may not fit into what their requirements or what they need may be. So even allergenic problems or reaction to the stomal bag or stomal wafer may be encountered as well. So peristomal related problems or complications are very much prevalent nowadays, which are usually addressed by the enterostomal therapist. There are some circumstances where a patient, particularly people who are more obese in nature, and there's a bit difficulty in bringing out the stoma. So the stoma may undergo some degree of detachment or retraction or separation can take place, and so these are problems which are many times, to some extent, can be addressed by the intrastomal therapies, but sometimes they may require a refashioning or the surgeon to intervene to address these problems. Now, prolapse and bleeding also are problems which also sometimes can encounter, particularly when the orifice, so the opening inside the abdominal aperture may be slightly big. They may encounter problems like prolapse or even herniation for that matter, which is why I was highlighting the fact that initially when the stomas are created, they usually are created within the rectus muscles to minimize problems of these nature, because the rectus muscle does provide a bit of support to the ostomy. Now, now this is a slide I think I'd just like to just run through. It's very simple terminologies, which I feel personally, it's my own personal views actually, to be honest. Stomas, I think, should be created with due consideration of the risks and benefits they offer. The long-term consequences of having stoma can be profound, both physically and psychologically. We know that for a fact. Nobody likes to have a stoma, but in some circumstances, some patients, they may accept it more easily, but some may never accept it, So now a surgeon only has a short-term involvement in a patient's care, but in enterostomal therapy nurses, I think they usually have longer follow-ups, which is just to imply the significant role played by the ET nurses. Now, if there are genuine benefits of the stoma, they must also be created in its best possible way. I think that's very, very crucial. Whenever I give my talks, even to the surgical fraternity and departments, I think the problem is stomas are usually created at the tail end of the operation after major resection and reconstruction. So as we know, we are more focused in the removing all of the cancer or resecting the bowel and so on, because that's obviously it's important, because in most problems, if there's leakage or something happens in those circumstances, the impact can be quite serious. So the focus of attention usually is always on the primary tumor or the resection of the primary organ itself. And stomas are usually created at the tail end of the operation, so there may not be much of focused attention paid on the stoma. So many times surgeons, sometimes in the public sector or in teaching hospitals, for instance, they leave it to the juniors, to manage the stomas, which I think, again, is nothing wrong. I think juniors has to learn, but the problem is sometimes if they do it without much supervision, so on, that's where the problem arises. So I think the psychosocial impact, can be affected, influenced by the way the stoma is creation. So why I always imply that a lot of focus and attention has to be not only on the primary surgery itself, but also on creating a stoma, especially patients who are going to be living with the stoma lifelong. And then the other important thing is educating, counseling, and the long-term support of managing a stoma is also very, very crucial. So in conclusion, I think stomal care, as we know, is an indispensable part of a multidisciplinary colorectal team. And this colorectal team is not just the surgeons alone. I think it's a team of many other disciplines. The enterostomal therapy inclusive, the physiotherapist, the nursing staff, the dietitian, everyone plays a very important role. I think it's also important to keep abreast with the current advances and refined indications of stoma creation. Creation of a stoma and its management involves a very holistic approach that begins in a preoperative patient, preoperatively, and continues for the rest of a person's life. I think just to end with a little short quote, I think a surgeon adds years to a person's life, whereas an enterostomal nurse adds life to the years. I think this is a very significant message to all the enterostomal nurses who I think play a very crucial role in the management of patients with ET, with the stoma. Okay, with that, I thank you. I think we are 8:55 now. There should be some time for Q&A, and I'm open to any questions that you may have. Yeah.
If anyone has a question, you may unmute and ask your question away.
Question in the chat box. Can I read out for you? It's actually from Kiki. She asked, ileostomy, how do we prevent electrolyte imbalance?
All right, just a minute. I'm trying to open up this. Sorry, I just can't. I'm trying to get out get the chat box out. I can't see it. Okay, sorry. Yeah. Okay. Yeah. Thank you for the question. Now, so electrolyte imbalances post ileostomy creation, it's always a challenge, particularly in the elderly group of patients. And again, I think first and foremost, if you understand the small bowel or small intestine, it's the longest part of the digestive tract, right? It's a couple of meters, 3 or 4 meters long. So first and foremost, to minimize the imbalance, what we do as surgeon is bring out the terminal end of the bowel as a stoma. Yeah. So meaning to say that the joint between the ileum and the cecum is called ileocecal valve. What I tend to do is at least just about 20 centimeters from the ileocecal valve is the point usually I'll bring out as a stoma. So the more distal we go, the more further down we go, the lesser the problems may be. The problem arises when the stoma is more proximal in nature. That means higher up. Yeah? So there's not much of time and there's much of area or surface area for absorption, for instance. So that's one in technical views. Yeah? How do we minimize electron imbalances? Is taking the distal most segment of bowel as a stoma. Now, when a stoma is created, sometimes inevitably, no matter how distal we may be, patients sometimes inevitable can still end up with the electron imbalances. So how do we minimize those kind of circumstances? First and foremost, when at time of discharge, we always reinforce to the patient and also the family members and the caretakers to ensure that the adequate amount of intake, oral intakes. And particularly not just drinking a lot of water alone. Water obviously is good for health, good, it's something we always encourage, but more electrolyte-based solutions. Even our simple solutions like the ORS, the oral rehydration salts you have for patients who've got diarrhea, taking those packets, for instance, or even solutions like we have the even solutions like Gatorade or 100 plus. Take out the gas, keep it standing in the glass for a bit of time, and ensure they take more of these electrolyte-based beverages. So keeping well hydrated is important. And more so if they can basically even like monitor. I usually like to have patients who can monitor the output. And when it comes to the follow-up, so first visit in my clinic would be first visit after surgery will be 1 week after the initial operation. And that primarily is to look out for things like this. Are they coping well with their losses? Are they having adequate intake and so on? So it's not just to evaluate the wound and so on. I need to have an evaluation of whether the intake is adequate and they are maintaining losses. And I do repeat a blood test. If I feel that they are getting a bit lethargy and tired and so on, I would always do a blood test to evaluate what the electrolyte levels are. Many times, the first thing that catches on my side will be the sodium counts below. So if that happens and they are not taking adequate amount of sodium, usually we'll advise them to just stay in the EDO for a while, just to put them an IV drip. So again, these are not common, but they are problems that we do encounter on and off. And the extreme nature would be sometimes when they go to such an extreme stage, they may become so dehydrated and they develop even a renal impairment, So we want to avoid those kind of problems. So anyone with ileostomy, usually I tend to see them very closely initial period. At least when I know they are managing things well, then I tend to let them more, independent. Yeah, sorry, that's one. Is there any restriction on diet intake? Sorry, I lost that. There's a few questions jumping. So yeah, there's a question: is there any restriction on diet intake, especially for those who have a stoma? Yeah, there is. So what I would usually advise is basically avoiding things which we do not digest easily, the initial period at least. And that entails fiber made material. Excuse me. So cutting down on fiber intake, the initial period of time. Fiber obviously implies things like, green leafy vegetables, things we don't digest easily. Even, for example, things like your fruits and all that stuff. People love to have fruits. I will say they can have your fruits, but basically like take out the skin. That's fibrous in nature. For example, apples, take your apples and so on, take out the skin. Grapes, take out the skin. And always try to avoid taking seeds and things like that at the same time. But I'm usually not very restrictive in nature, because I realize that sometimes when the patients we become too restrictive, and the patients like to eat what they want to eat, they won't eat anything at the end of the day. So I am a bit liberal in terms of what their intake is. I usually say, enjoy. You have to have some food, otherwise you don't eat anything. So, but mainly post stomal creation, usually I would advise the general rule will be minimizing on too much of fiber intake. And so the other one is, there's another question here by Theo. I have two fistulas, a rejoin and another near the belly button since September 22. What do I need to do to close the fistulas? What diet I need to observe? I normally have my tummy growl at 11 p.m. So again, when you say fistulas, I'm assuming these are some enterocutaneous fistulas. Are they fistulas from a small bowel to the skin? And so they are not stomas, right? So because stomas and fistulas are two different things, and fistula just means to say there's basically a communication between the small bowel, or there may be some kind of leakage when it taken place. I'm not sure about this, or about what you have here, where there's communication between the bowel which to the exterior. So if there's two fistulas, I think it's just important to ascertain where the fistulas, which part of the bowel is fistulating outwards to your skin, right? Usually, as fistulas are very so what's relevant in the fistulous tract again is to address the volume that comes out. What are the contents that's coming out? If you've got a very low fistula, low output fistula, I won't be too alarmed. But sometimes when the fistula is very high output, that's where you may end up with problems. Predominantly the same thing, electrolyte imbalances and things like that. So it's important so the management of fistulas will depend on a lot of variables, to be honest. What is the causation between fistula? What type of fistulas are they? Are they malignant fistulas? Is there some inflammatory condition underlying? Because if they're malignant fistulas, they will never close up. So we need to really sit down and address what exactly is the etiology behind the fistulas, or is it secondary to a leakage? So there are a few things that we need to address here. I think you can probably furnish more information if you like, Theo, and I'd be happy to address that if you can. And yeah, so if it's a very low output fistula, won't be too restrictive for your diet again. But if it's high output and so on, then we probably have to think about parenteral nutrition and again. But I think the most important relevant pointer here would be what is the causation of the fistula, and and also whether it's, like I said, if it's malignant in nature and all that. So these tracks will not close unless we address the prime problem.
Doctor Theo here regarding the fistulas.
Yep.
As far as I know, according to the conversation, to my knowledge at that time, this is like something like an overgrowth from the normal intestines, and there's like one vessel going to the skin. And my output normally is low, but at times when I eat wrong things, it tends to be abnormal. But when it's abnormal, it's not that like it's half the bag that is full. It's always about like maybe about 10% of the capacity of the bag, or at the most about 20%. So
So-
as the months goes by, but lately in November, I by using more of the DIY myself to actually to understand my body better. But I believe that when I have a gas in my stomach and the gas doesn't comes out through the anal there, I can hear that the hissing gas coming up through the fistula. So it's like the gas are taking a shortcut instead of going all the way down, it goes up to the fistula. So I have to manage that the gas portion, which I think is partly because I'm hungry. So when I hear it start to grow, then I look for food to eat.
Okay, so you've what is the primary operation you had? If I may ask, what exactly do you have?
Primary operation was mine was a rectum tumor. It was removed in October 21.
21. So you had a primary resection and primary joint done. There was no stoma you had, is it? Did you have a stoma?
I have a stoma from that operation in 2021, and I have a rejoin in in August 2022. In September 2022, the two fistula came about, which actually
Okay.
disrupted my
Of course. Yeah.
my movement.
Okay. So the fistula came about after you had a closure of the stoma.
Correct.
The prime problem was rectal cancer. So, well, but you said that there are two openings now, and so there are two openings, which you say in certain days they're by much high output, some days they are low output.
Yes,
Yeah.
yes, and especially when I eat the wrong things. Like for example, if I eat I like to eat something like chicken chop or pork chop like that, and sometimes it's marinated with black pepper. That black pepper I can't touch now, so I notice. So the
Yeah.
things that comes out, it irritates my thing a lot, and in terms of the gas volume as well as the discharge, also it's also dark in color.
Okay, so what I would advise. Okay, I'm pretty sure that person who did the primary surgery, he's already done the scans after he had a
Yes,
fistula. He's explained to you where the track comes from, isn't it? Yeah.
yes.
And so that's relevant, So we need to know where exactly the track is and what is causing the fistulous track. Did he mention there's some? Is it a cancer-related track, or is it something else? Or did he mention all that? Or
He didn't mention there's cancer related cancer related ones, but I believe that this could be through the blood vessels somehow maybe from the radiotherapy it becomes not like enlarged.
Yeah.
As per my understanding lah.
Yeah. So
Because
I
when
mean,
he explained that time,
yeah.
it was a bit scientific.
Yeah, so it won't. Well, it may be blood vessel related, but fistulous tract means it implies bowel related lah. Is it some? And the fact that you say some effluent coming out which bowel contents, so it's all related to your bowel leaking to your
Okay.
skin. The good thing about fistulous tract is that there's all usually these are mature tracts where the flow comes out of the skin. It's not leaking inside the abdomen.
Yeah, correct.
So if you have leak inside the abdomen, you won't be well. You'll be very, very sick.
Yes.
So the fact that it's coming outside and it's probably got a very matured kind of track. Now, I think, and you probably have been having this since 22 now, more than a year plus now.
Yeah.
I realistically, I don't think it's going to subside by itself until unless something more definitive is done, and which basically entails, firstly, I need to look into where the level of fistulous tract, what exactly is causing fistulous tract, and then deciding thereafter. Now, in sometimes small low output tract, which are, for example, which induced by, let's just say it's a leakage following surgery, which sometimes can cause a fistula as well. What we need to do is bring you to the hospital, keep you on the parenteral nutrition or what's called a TPN, fast you for a while, and some cause of antibiotics and so on, and just rest and see whether will that self close by itself for a low lying track, low output track, sorry. But if it's high output track, this invariably will not, usually will not work. So
True, but
again, yeah. So again, like I said, sometimes it's defining all this. And if the track basically is, if it's a bother to you, like you seem to have adapted to this now. If it's a bother to you, there are, of course, there's avenues of going in and probably, resecting it. But again, this is very loose term I'm using because I need to look into the whole picture before we can
fair
decide.
enough, fair enough.
Yeah. So we
But,
need to
but
look
my
at,
sorry, but my doctor did opine that if I because I think from the radiotherapy, I think my intestines are they are
yeah,
very close to, they are sticking to each other.
yeah,
So he
that's
says
right.
that no, the chances of doing the
Probably.
surgery
Yeah. Yeah,
of
probably.
me coming
Yeah.
out from the surgery room is not
That's
there.
right. So you're
And
right. Basically. There's radiation enteritis, radiation bowel. It's you see sometimes it's very notorious, and sometimes when you go in, things can be very plastered as all, and also so it may not be a straightforward thing.
correct.
Again, I think no, you've been living with this for 1 year. Like I said, there are avenues of addressing it. One way I can just say, since you already identify, what kind of risk factors would triggers off the problems,
Mm-hmm.
what food to avoid, for instance. My advice is probably just falling and listening to what your body tells you,
All right.
and if you're taking that approach of, living with this, I think that's the only advice I can give you, and yeah. So otherwise, it will be, like I said, we need to really investigate and find out more details before we can do something more definitive.
Okay, then the last question on my part is it always grows around about 10:30 to 11 p.m. So when I hear that and I know I've been eating frequent meals but in small portions and it doesn't seem to help. So I need to be back on this gastric medicines.
Yeah, yeah,
And
that's right.
I try to do away with that, but then that growling will come back again.
Yeah, but is it
When it
ground?
comes back again, and you can actually hear the hissing sound coming through that through the fistula openings.
Yeah, that's right. Well, it's an opening, so it has to find its way one way or the other. So
Correct.
it's an opening there. There's a channel, so invariably it will be. But you just have growling, but you don't have pain, isn't it? Yeah.
Oh no, just the growling thing.
Yeah, that's right. Okay.
Oh,
Yeah.
all
Okay.
right. Thank you for being with us and sharing your thoughts with us. Thank you very much, doctor.
No, 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 not at all. Not at all. It's a pleasure.
Okay.
And okay, right. So yeah, there's one question here on by earlier. Sorry, can't ask. Thank you, Sir President. Do you have any advice to handle stomal prolapse that is length around 15 centimeters and irreversible? Because my surgeon in my hospital advises to compress using gauze and regulated MX salt every 6 hours. Okay. Yeah, prolapse stoma, it's another entity, and basically, what in acute circumstances when you have a stomal prolapse, I think like what they advised, remedial measures of sprinkling. Some people use salt, some would advise even using like sugar, even like this max salt. I think is not a bad option as well. It usually and sprinkling that, and works a principle of hyperosmosis, right? So it helps reduce edema and so on. So in those circumstances, in acute prolapses, you can use those remedial measures. But in the long run, usually the only way of sorting this out would be refashioning the stoma. And I'm not sure whether the stoma is meant to be temporary or a permanent stoma. If it's a permanent stoma, then you probably have to consider refashioning. But otherwise, some circumstance, I did had someone not long back who had a stoma prolapse. I'm not sure if she's online listening to us today, and who had a low anterior and a covering stoma. She a bit on obese side. She did manage to end up with a stoma prolapse. So, but what we did was basically at the completion of, 6 weeks of a tenure of I did a gastrographic enema and I closed off the stoma straight away. So if these stomas are meant to be a temporary, meant to be a closure, I would just say go ahead straight for a stomal reversal or closure. But you mentioned it's irreversible. I'm not sure for what reasons. But if they are not irreversible, I think the only remedial measures I can tell you would be the simple maneuvers I just mentioned of applying, the hyperosmotic kind of a solutions, or sprinkle some salt, for instance, and that may help to remedy the problem. But in long run, the problem is going to recur again. So I think something more definitive would be in terms of refashioning the stoma. I hope I answered your question earlier. Yeah. Okay, earlier. So should I move on to the next question? Yeah. Reversal stoma, is it considered a major surgery, or the issues that it's unsuccessful and ended up being a permanent? I'm still having my stoma for 10 months and my surgeon wants to give me more time to heal. Yeah, so again, so stoma reversals, again, imply which type of stoma again. If it's like a loop ileostomy, like I was telling you about, which is meant to be as a covering stoma to cover a low rectal cancer surgery, low anterior section. It's not a major procedure. It's a relatively quite a simple, straightforward operation. And the procedure is done entirely around the stoma itself, we don't need to go back inside the abdomen for to address the closure. So a loop ileostomy, a loop transverse colostomies, which I mentioned earlier, these are temporary stomas, are generally simple, relatively simple procedures, and they're not major operations as compared to the initial primary major surgery. But if you're talking about reversal of a stoma, like a Hartmann's reversal, if you remember the diagram I explained earlier, a Hartmann's implies where you are closing the rectal stump. And let me just go back to the slides if I can show that to you again. So can you see the slide again? Now this is a picture of a Hartmann's procedure where a stoma is brought out, an end colostomy, and the rectal stump is left inside the abdomen. So, so when we need to close the stoma, obviously we have to go back inside the abdomen to look out where the stump is and mobilize, free the stump upwards cranially, and then close up the stoma and bring it down, releasing all the attachments above, and then anastomosing it. So this is more tedious kind of a procedure as compared to closure of a loop ileostomy. So again, to answer your question, reversal stomas, ileostomies or transverse loop stomas are usually very easy because both the ends are already there. We talk about loop stoma, the ends are already there. Both the proximal, the afferent and efferent loops are already sitting there in the skin itself. So all you need to just mobilize the bowel, free all the adhesions, anastomose. We can do the anastomosis. Why you usually use staples for anastomosis? Some would use hand suture, and then drop the stoma back in the abdominal cavity and close up the wound in layers, right? So that's basically for a loop ileostomy. So what are issues that it is unsuccessful and ended up being a permanent stoma? So there are multi different questions in this one question. So I suppose, see, generally speaking, whether a stoma is going to be permanent or temporary, I mean, at least my practice, I usually would address those issues prior to plans for a closure, or so I wouldn't plan for a closure reversal without telling them that I'm not going to be able to close it. But in some circumstances, the only time I probably can see this is when you plan to do a Hartmann's reversal, for instance, and you notice there's advanced cancer all over, or there's what's called a frozen abdomen, a frozen rectum, or a frozen pelvis, and probably in those circumstances, the plans for reversal may not be successful. You may end up with a permanent stoma. But these are rare circumstances. Yeah, so your stoma has been there for 10 months and wants to give more time to heal. I suppose my only advice to you would probably, listening to your surgeon. I think they will know best because, they're the one who encountered their primary problem, and they know the seriousness of what you had to go through. Yeah, so sometimes it's good to understand what the primary problem was, and listening to what they have to advise. So there may be their own reasons why they advise to keep it for a longer period of time, and not to rush into closing the stoma. All right, I hope I answer your questions, Jennifer. Yeah.
Dato, there's one more question from Kiki just before Jennifer's question.
Okay.
Ileostomy, what is considered a normal output volume?
Oh, okay. All right. Okay, that's a good question. Yeah. Sorry, I overlooked this. Okay, right. Then missed out a 1-2 liner question. Yeah. Yeah. So very realistically, there's no fixed volume output, but most of the time you would expect nothing less than 1 liter. Right? Nothing less than 1 liter. And I think if you have more than 2 liters, I'll be a bit concerned, and because you may not. So usually it's 1.5, 1 to 1.8 liters around that figure of time. And so, yeah, so majority times be more than 1 liter. So usually an average of 1.5 to 2 liters. Does that answer your question? Ms. Wong, do you agree? I don't know. Ms. Wong is, I know a lot of you ET nurses here are the experts who know they know a lot more than I do here. And, but they just keep quiet. They don't say much. Ms. Wong is one of those. She's a pioneer when it comes to intrastomal.
No, we have got the first ET nurse in Malaysia. She's in, and I think she asked a question.
Oh, sorry, who is this?
The first ET, okay, Miss TP Tan. So let me ask.
Oh, fantastic. Oh.
Yeah, she's asking Dato how to avoid hernia from happening.
Okay, well, sorry, just 1 second. Okay, yeah, first, it's an honor to have you with us. Just done, yeah. So hernia again, no, it's a nuisance. Firstly, to have a hernia. Hernias are one of those complications usually related to more of a later stage complications compared to many of the complications that we usually encounter. So and this usually results in primarily like I said, it applies to even the techniques when the stomas are primarily created. I keep reinforcing the fact that when a stoma is performed, many times the locality and the technique of creation is very, very important. Now, generally, I'm a surgeon. I can tell you very frankly that most of the problems of a stomal related issues are usually on creation, how its technique is being done. So it all goes back to the primary person who does the stoma itself. And some circumstances, particularly in emergency situations where patients are, in very bad, severe sepsis and everything's still plastered down, people are very obese, for instance, bringing out a stoma can be quite an ardent task. And so in those circumstances, sometimes the tendency of having a stoma, which may, for example, retract and all that, it's something we do occasionally encounter. Now, so the techniques are very, very relevant. So the same thing applies in terms of even stomal or peristomal herniation. It applies to the technique of creation. So one time when we do a creative stoma, like I said, the likely sites where the stoma should be performed is very crucial. And one of the most important factors I look into would be within the rectus muscles. And usually what I tend to look at is the summit of the infraumbilical bulge of fat. So when I squeeze out the bulge of fat below the belly button and find the summit of that and within the rectus muscle, and that's usually my ideal position where the stoma is performed. So this basically would lessen the chance of a herniation. If you go beyond this area on the more lateral position, the risks of herniation is much higher. Now, the other problems are usually when the patient manifests a hernia. Obviously, it's also when the aperture, the size of the opening is too large, for instance, so that also can predispose to a herniation as well. Now, these are more surgical related factors. Of course, there's always patient related factors as well. When they start having to strain too much, there's increase in intra-abdominal pressure, just like any other hernia, anywhere else for that matter. Why do people develop hernia? Sometimes there's increase in intra-abdominal pressure because of obesity or some other reason. The risks of herniation are much higher. So I hope that answers your question. Yeah. Okay. Any other questions?
Thank you, Dato. Yeah, she say yes. And I think from nursing point of view, we also advise them not to carry heavy objects after the
That's right.
surgery, at least for about 3 months. And also, even sometimes they are not aware. I have a patient who is actually very hardworking. She did all the scrubbing of the toilet and all that after, I think, within the first 2 months. So she actually developed hernia, not hernia, prolapse.
Yeah.
I think sometimes we have to actually, I mentioned to her, but I think we have to off and on remind them so that they know what is actually, they need to prevent hernia and prolapse by avoiding all those very, very strenuous job. Yeah.
That's true. Very true. Yeah.
Mm. Yeah. I think there's no more questions, maybe.
Okay.
Okay. Uh,
Any questions otherwise? Yeah.
Participant can just unmute and ask questions because some of you may not be very comfortable with chat box. So you can just unmute and ask.
Hi, Doctor. I'm John. I just have a question. Is it very common to have your stoma sometimes bleeding?
They can, yeah. It's not a common issue, but it can bleed as well. And no, I do rarely get called in sometimes in the emergency department, sometimes from the medical officer saying, "Doctor, the patient's admitted some bleeding from stoma." You know, the first thing I usually tell these patients, the medical officer when they come in, is just to open the bag, have a look and see. Most of the time, the site of the bleed would be from the peristomal area.
Yes.
You know? And it's a very simple thing to do. Or usually I just say, just take a cotton ball and just press on it for 2 minutes. Invariably, the bleeding subsides. So, and many times, like, the skin around the peristomal issue, the skin is usually very fragile and so on. Sometimes we wafer, improperly applied appliances, they can breach into the bridge, especially a point where the sutures are placed, so they can bleed occasionally. So many times the bleed would be from the peristomal skin. Now, the question is basically if they can't find the bleeder from the peristomal area, the source there, whether the bleeding is coming from the inside the bowel. So that's entirely a different ballgame.
Yeah.
There's bleed from the inside the viscera that warrants investigation, that warrants an evaluation, maybe a scope or something of some sort, But like I said, majority of times the bleed would be from the peristomal area.
Okay. Thank you. And I'm also due to have a colostomy sometime in December with a stoma. Should there be anything I should prepare myself for? I mean, is it still business as usual when you do a colostomy, coloscopy with a stoma?
So sorry, you've already had surgery and you are planned for a colostomy, colonoscopy through the stoma. Is that what you're saying?
Yes.
Through the stoma. So you've had what surgery? You had an APR. Did you have an APR or what?
Um, I had a resection.
Okay.
Part of my colon was removed, and then there's a stump. What was that? Hartmann's procedure just now? What you usually?
Okay, Hartmann's procedure here. Yeah, that's fine. Well, yeah, we do occasionally do colonoscopies through the stoma. There's no problem. It's just as usual, and you probably have to go through the bowel prep as how it's usually done, and no issues at all. It's just that probably. Yeah, when we do a colonoscopy, when you put the stoma, it's just the position of the patient itself. You just left supine, and it's done usually under short sedation. No big deal. No issues. It can be done.
Okay.
Yeah.
Thank you.
Okay, all right. Are we good?
Okay, I pass back to Puan Sarah. Puan Sarah.
Thank you, Dato. Thank you, Miss Wong. I thank you so much, Dato, because for the insightful sharing. It takes away my fear. I have low colostomy and looking forward for the reversal soon, hopefully very soon.
Oh, very good. That's good. Good to hear. Yeah.
So I think if there is no other question, that would mark the end of our session today. Thank you for the sharing, Dato, again, and thank you for all the participants that joined us tonight. And we will see you again next week, inshallah.
All right. Thank you. Thanks.
Thank you.
Keep up the good work. Good.
Thank you, Dato.
Thank you.
Thank you. Thank you. Thank you. Bye.
Bye-bye. Good night, everyone. God bless.
Good night. Thank you very much.
Thank you.